Hello, this is part 3 of a guide to clinical reasoning, or how to create an accurate differential diagnosis from a patient's presentation. To remind you, here is our practical 5-step bedside approach. In this part, I will demonstrate how to use the approach with an intern-level case. As I did in part 2, I'll present this patient to you the same way that an intern might present the patient to his or her attending on rounds, or to their colleagues during a morning report or teaching conference. Again, I'll keep a running list of the key features as I go. For practice, consider writing down the key features while listening to the presentation, but not watching it. I also would consider stopping the video before the discussion of the problem representation, framework, and application of key features to first see what you can come up with on your own. The chief complaint is a 58-year-old man presenting with recurrent chest discomfort over the past 2 weeks. Mr. Jones is a 58-year-old smoker with a history of hypertension who is in his usual state of health until 2 weeks prior to admission, at which time he experienced an episode of chest discomfort. The pain came on over the course of several minutes while he was moving some boxes in his garage. It is located in the center of his chest, and he qualitatively describes it as a dull aching and heaviness. He stopped moving the boxes, and the pain gradually subsided over the course of 5 minutes while he was resting. He also was a little lightheaded during the episode. He denies any radiation of the pain or other associated symptoms, including shortness of breath, nausea, vomiting, diaphoresis, or palpitations. Since that initial episode, he has had approximately 5 more similar episodes, each lasting about 10 minutes in total, and each associated with varying degrees of lightheadedness. Some episodes occurred with some form of exertion, such as walking up a flight of stairs, but at least 2 began at rest, including one on the morning of admission that lasted longer, about 20 minutes. His past medical history is notable for hypertension and obesity. His past surgical history includes a cholecystectomy 10 years ago and a right knee replacement 1 month ago. Medications are lisinopril 20 milligrams daily, metoprolol 25 milligrams BID, aspirin 81 milligrams daily, and simvastatin 20 milligrams QHS. For his social history, he lives with his wife in San Jose and has 2 children. All of their health is excellent. He is a retired mechanical engineer. He continues to smoke 1 pack per day, as he has for the past 40 years, but does not drink alcohol. His family history is notable for a father who passed away at 76 from pneumonia. His mother is alive at 83 with diabetes. On physical exam, he is a moderately obese man in no apparent physical distress, but appears slightly anxious. His temperature is 97.9 Fahrenheit, heart rate 86, blood pressure 152/92, respiratory rate 20, and oxygen sat 94% on room air. His BMI is 35. HENT exam is normal cephalic with normal oral pharynx. Neck is supple with no bruits, no thyromegaly or nodules, and no lymphadenopathy. His chest has normal excursion, is cleared of percussion and auscultation bilaterally. His cardiac exam shows a regular rate and rhythm. S1 and S2 are normal. There is an S4 heard at the apex, but no S3. There is a 2 out of 6 uniform systolic murmur heard best at the left lower sternal border and without radiation. His JVP is not visible, presumably secondary to his habitus. There is no chest wall tenderness. Abdominal exam is non-distended. There is no tenderness or guarding. Spleen is non-palpable. Liver is non-palpable. His musculoskeletal exam shows full range of motion at all joints and no bony abnormalities. He has no edema in his lower extremities. On neural exam, his mental status is fully intact. Cranial nerves 2 through 12 are intact, and 1 was not specifically tested. Patellar, ankle, and biceps reflexes are 2+ bilaterally. Motor strength 5 out of 5 in all major muscle groups. Gait was normal. On labs, his CBC, complete metabolic panel, Troponin, CK, and UA are all normal. A urine tox screen was also negative. A chest x-ray was also normal. His EKG shows normal sinus rhythm with a QRS axis of negative 45 degrees, high voltage and T-wave flattening in leads 1, AVL, V5, and V6. There is no pathologic Q waves or ST segment deviation.
So I just completed steps 1 and 2. The next step in our 5-step approach is creating the problem representation. Remember, the problem representation is a 1 to 2 sentence summary using precise medical terminology of the most relevant key features of the patient's history, exam, and diagnostic tests. These are the key features that I feel are the most important in this case. For the problem representation for this patient, we would start with Mr. Jones is a 58-year-old man. Since one of the goals of the problem representation is to be concise, if it's possible to group together or summarize related parts of the history, you should. So hypertension, obesity, and active smoking become multiple cardiovascular risk factors. The surgery may become relevant, so let's include that as well. When listing the key features of the chief complaint, I've already started using some semantic qualifiers, so if I continue that trend, we would say that he is presenting with acute, episodic, inconsistently exertional chest discomfort. Finally, the highly relevant diagnostic data includes the unremarkable vitals, which we can summarize as he is hemodynamically stable, which to a much lesser degree also includes the fact that there were no signs on exam or labs of shock. He is mildly hypoxic, and will end by summarizing the normal cardiac enzymes, lack of Q waves, and lack of ST segment deviation as without evidence of acute infarction. So altogether, Mr. Jones is a 58-year-old man with multiple cardiovascular risk factors and recent surgery, presenting with acute, episodic, inconsistently exertional chest discomfort. He is hemodynamically stable, mildly hypoxic, and without evidence of acute infarction. Okay, now let's go back to our 5-step method. We're now at step 4, adopt a framework. What framework should we use here? I'm going to display our problem representation again, since the framework we choose is essentially driven by this. One of the major reasons for creating a problem representation is to help with framework selection. The most common framework for chest pain is one based on the organs or anatomic structures in the chest and upper abdomen. For example, structures in the chest include the heart, lungs, aorta, esophagus, and chest wall. Here are some specific diagnoses related to those structures that can cause chest pain. And in the abdomen, we have the stomach, the small and large bowel, and some relevant diagnoses. This is conceptually similar to the framework used for abdominal pain in the last case. Although I said that this is a common framework to use for chest pain, and I think it would be similar to the one most clinicians would use, it's not the one I personally would choose for this specific problem representation. I would not classify using this framework as a mistake per se, I just happen to think there is a better option. Let me read that first sentence of the problem representation again. Mr. Jones is a 58-year-old man with multiple cardiovascular risk factors, presenting with acute, episodic, inconsistently exertional chest discomfort. This description suggests that Mr. Jones doesn't have undifferentiated chest pain, but rather he may have something quite a bit more specific: unstable angina. That is, chest discomfort that is specifically caused by lack of adequate blood flow to part of the heart, which is either new or getting worse with time. Since this problem representation is more specific than chest pain, the best framework to use should be more specific as well. Therefore, I would use this one instead, which focuses on the mechanisms of angina rather than anatomic structures and organs. This will reinforce an improved understanding of the patient's underlying pathophysiology. We have angina caused by decreased oxygen supply, angina caused by increased oxygen demand, and then angina mimics. Also, while you may notice many diagnoses have shown up in both frameworks, by using the most appropriate framework, additional, potentially relevant diagnoses have been suggested that you might otherwise not have considered. Two additional notes about this framework. First, the general category of angina due to increased oxygen demand is frequently referred to as demand ischemia. Second, the diagnosis at the top of the decreased oxygen supply category is listed as unstable plaque from CAD or coronary artery disease. That's sort of equivalent to common usage of the term unstable angina. The problem is unstable angina is technically a symptom or a symptom syndrome and not necessarily a pathophysiologic mechanism, despite its frequent usage as such. Therefore, while I'll be using the term unstable plaque moving forward, many people would refer to this specific diagnosis as unstable angina, or alternatively as acute coronary syndrome. Some of the terminology is definitely a bit confusing. Returning to the overview of the 5-step approach, we're now at the last step, applying the key features from step 2 to the framework from step 4 in order to generate a differential diagnosis. So here's our framework on the left and our key features on the right. There are two reasons why I consider this case to be an intern level case and not a student level one. The first is because the optimal framework is one that is not based on anatomy, but rather on physiology, which is less commonly employed and requires a little bit more thought. The second is because the provisional diagnosis seems so obvious that it requires conscious effort to simultaneously consider other plausible diagnoses without falling into the trap of including the complete list of every possible cause of chest pain. To generate the focused differential, the best place to start is with the diagnosis mentioned in the framework, which is, overall, the most common cause of the chief complaint as characterized by the framework. So in this case, the framework categorizes Mr. Jones's chief complaint as unstable angina, and overall the most common etiology of unstable angina, at least in a 58-year-old man with multiple risk factors, is an unstable plaque from coronary artery disease. So we'll start with that diagnosis and try to link the most relevant key features to it. The fact that the patient is a late middle-aged male raises the probability of unstable plaque. Many of the individual elements of his description of the chest discomfort slightly increase the chance of unstable plaque when looked at individually, but when considered together collectively, the chest pain story, so to speak, is almost textbook for unstable angina from an unstable coronary artery plaque. Likewise, when each cardiovascular risk factor is analyzed in isolation, each one slightly increases the probability that this is from CAD, but with a dramatic cumulative effect. The physical exam is surprisingly unhelpful in diagnosing unstable angina from CAD. The fact that the troponin and CK are normal actually have minimal to no impact on the probability of CAD here, since they are only elevated in infarction and not in ischemia. However, the EKG's lack of any evidence of present or past ischemic changes very mildly argues against CAD. In no way does that mean a patient can't have a normal EKG in either CAD or even during an acute MI. That certainly happens. It's just that a normal EKG is more commonly seen in most other causes of chest discomfort than in CAD. So from the fact that we've already identified that unstable plaque is the most common cause of unstable angina in this age and gender, with this collection of medical problems and from the relatively consistent chest pain story, it's safe to conclude that unstable plaque from CAD will probably end up as the most likely explanation for the patient's presentation and thus the provisional diagnosis. For additional connections between key features and diagnoses that my brain might make at this point, let me just run through each diagnosis as it's listed on the left. The next diagnosis on the list is coronary vasospasm, which is also known as variant angina and occasionally by the eponym of Prinzmetal's angina. Coronary vasospasm is neither particularly common nor particularly rare. Among the patient's key features, there are two which are most relevant. First, he is an active smoker, which is a risk factor for vasospasm, and thus this argues in favor of the diagnosis. Second, as vasospasm is typically not related to exercise, the patient's observation that the episodes are occasionally exertional in nature mildly argues against this. Aside from its non-relationship with exercise, vasospasm otherwise symptomatically mimics angina from CAD quite well, and there are no typical exam or routine test abnormalities seen. Therefore, the other key features are not particularly relevant for this specific diagnosis. Anomalous coronary anatomy and coronary thromboembolism are both quite rare entities that I would not entertain in the absence of some element of the presentation that specifically suggested them. How about tachyarrhythmia? A tachyarrhythmia, such as paroxysmal atrial fibrillation, could transiently increase the heart rate to dramatically elevated levels, increasing oxygen demand beyond what the coronaries can supply, leading to symptoms indistinguishable from angina. The biggest argument in favor of the tachyarrhythmia is its relatively high prevalence compared to most other items in the framework. Additional key features that argue for this diagnosis include the lightheadedness with some episodes. Lightheadedness is not particularly common with angina from CAD, but can be caused by low cardiac output in the setting of severe tachycardia. Also, the EKG has features of LVH, which can lead to or is indicative of increased left ventricular pressures, which then would eventually lead to left atrial enlargement, predisposing the patient to arrhythmias such as AFib, though that's a little bit of a stretch. A key feature that mildly argues against an arrhythmia is the lack of associated palpitations, but certainly there are people with paroxysmal AFib and other tachyarrhythmias who lack palpitations, but they are probably in the slight minority. We'll pick up the pace a little for the remaining diagnoses. Aortic stenosis is argued for by the presence of an S4 and the LVH on EKG, both of which can be the consequence of AS. However, AS severe enough to cause angina almost always has physical findings of the diagnosis, particularly a classic systolic harsh crescendo-decrescendo murmur at the upper sternal borders, radiating to the carotids. Although this patient has a systolic murmur, its other characteristics are not consistent with AS. That's not to say it's impossible to be caused by AS, just unlikely. For the most part, the arguments for and against AS are the same as for hypertrophic cardiomyopathy, including a murmur that is not characteristic. An additional consideration is that hypertrophic cardiomyopathy typically presents younger than this patient. Also, overall, hypertrophic cardiomyopathy is significantly less common than AS. Pheochromocytomas can definitely cause chest discomfort from excessive oxygen demand during episodes of extreme hypertension. However, in addition to being quite rare, pheochromocytomas almost always present with other symptoms during the episodes, such as headache, palpitations, and tremor. Their absence, combined with the rarity of the diagnosis and significantly more likely alternatives, rules out pheo. Surreptitious stimulant use is essentially ruled out by a negative urine tox screen. There are certainly stimulants that aren't routinely tested for, but nothing in the history is suggestive of this. Pulmonary hypertension is an interesting consideration. Two historical key features argue for this: his obesity and his smoking, which can lead to OSA and/or obesity hypoventilation syndrome, and COPD respectively, all of which can cause pulmonary hypertension primarily through the mechanism of hypoxic vasoconstriction. Two exam features also argue for it: his hypoxia and the systolic murmur, the description of which is most consistent with tricuspid regurgitation, which is always seen in severe pulmonary hypertension. There are two key features that argue against it. First, the EKG. The majority of patients with pulmonary hypertension severe enough to cause angina-type symptoms have EKG findings of right ventricular hypertrophy, failure, or strain. This patient has none of those. Also, the patient has no shortness of breath. Although pulmonary hypertension is overall a relatively common and underappreciated diagnosis, it usually presents with either shortness of breath or other findings of right heart failure, which this patient lacks. Still, as the only plausible etiology that clearly explains the hypoxia and the murmur, it will probably make the cut when it comes to the differential. Now we move on to the angina mimics, which includes several don't miss diagnoses. For aortic dissection, although smoking is a risk factor, pain from dissection is usually described as sharp or tearing and not as a heaviness. It is rarely, if ever, episodic in nature, and given that it is rapidly fatal if not immediately treated, it seems highly unlikely the patient could be having symptoms for 2 weeks and not yet have died. Also, although a lesser consideration, a normal chest x-ray argues mildly against the diagnosis, as aortic dissection usually causes mediastinal widening. Overall, although it's a don't miss diagnosis, I think we can rule out aortic dissection on the basis of the highly inconsistent history. And by the term ruled out, I mean the diagnosis is so unlikely that despite its severity if it's missed, it no longer merits further testing or further consideration. Another don't miss diagnosis is PE. He has 2 PE risk factors. The more obvious is the recent surgery. The less obvious is his smoking. Another key feature in favor of PE is the hypoxia. Hypoxia does not impact the probability of a PE among patients presenting to the ER with shortness of breath as a chief complaint, as many other causes of shortness of breath are associated with hypoxia. However, it most likely increases the probability of a PE among patients presenting to the ER with chest pain, since the only other etiology of chest pain clearly associated with hypoxia is pulmonary hypertension. Does anything argue against PE? First, though to a lesser extent than pulmonary hypertension, PEs usually present with some degree of shortness of breath. Pain from PEs also is usually neither episodic, exertional, nor mid-sternal. While none of these elements or key features in isolation argue very strongly against PE, taken as a collective of features, we would say that the overall description of the discomfort is highly uncharacteristic of PE. And although I did not previously consider it a key feature, the lack of physical findings of a DVT also argue against the PE. Although the patient is not tachycardic, as we would usually see with a PE, he is also on a beta blocker, so his normal heart rate cannot be counted against the diagnosis. Overall, although this is less clear than it was with the aortic dissection, I think the arguments against PE are strong enough that I probably would consider it ruled out at this point based on history and lack of DVT evidence. Anxiety is relatively common, and of course it's suggested by the fact that the patient subjectively feels anxious. However, the exertional nature is not typical for this diagnosis, and the chest discomfort description overall is not particularly consistent with anxiety, though largely because it is so consistent with several other previously discussed diagnoses. So although I don't think I'd consider anxiety completely ruled out, it's definitely relatively low on the differential. Finally, chest wall pain, sometimes given the name costochondritis when it's localized to the costochondral junction. Nothing in the history suggests this diagnosis, and although I haven't previously listed it as a key feature, if you remember from the exam, there is no chest wall tenderness, which argues significantly against the diagnosis. So now we've applied the key features to the framework to adjust the likelihood of the various diagnoses away from their overall prevalence in the population. It may have felt like quite the exhaustive and thorough process, and in some aspects it was, such as the time it took me to discuss my thought process. The good news is that when you aren't discussing this out loud, but rather thinking through these diagnoses and making those links to specific key features in your head, this process is much, much faster and only increases with speed and accuracy with experience and deliberate practice. From this process, we can construct our differential diagnosis. As mentioned a few minutes ago, the combination of his highly consistent symptom description, his multiple risk factors, and the overall high prevalence of CAD, an unstable plaque from CAD, usually referred to as unstable angina, is clearly the most likely diagnosis. Next, the combination of its prevalence in the general population, the associated lightheadedness, and the suggestion from the EKG that the patient may be prone to high intracardiac pressures and or left atrial enlargement suggests a tachyarrhythmia leading to paroxysmal demand ischemia, as the second most likely diagnosis. From this point forward, the exact order and overall number of the remaining diagnoses is open for debate. If we consider that the differential diagnosis should include all diagnoses whose likelihood or severity is high enough that they warrant additional testing, and may also include one or more other diagnoses which are common but which you may not be specifically testing for at this time, I would round out this patient's differential with coronary vasospasm, pulmonary hypertension, and anxiety. While most differentials also include one or more so-called don't miss diagnoses, the only such don't miss diagnosis for this patient is the aforementioned unstable plaque or unstable angina. And unlike the case from Part 2, there are no unusual feature diagnoses in this differential. I want to be clear that this is not the only right differential diagnosis, nor even necessarily the best or most accurate. It's just the one that's generated by the combination of my personal knowledge and my personal experience.
So that concludes part 3 of 3 of this video series on clinical reasoning. I hope you found it interesting and useful. If you found these videos helpful, please remember to give them a thumbs up, and if you have any questions, please post them as video comments. I try to personally answer all questions in a timely manner.